American actually have, and you probably went, yep, just like I thought. but, but
You have you should be English. You have self-deprecation down to the T.
I, but to me, it makes perfect sense, because when you say to make the bone echo as thin as a pixel, and I forgot the other thing.
Right as a button, we say in England.
And as bright as a button. I have cared, as I have actually imaged bone now over the course of the last several weeks. I've cared about what you're talking about.
Yeah.
But it's I believe it mostly involves understanding the physics of it. And you said, is it fair to test people on things that they don't? How broadly ignorant is the population of MSK ultrasound users?
Well, I think if I know some pretty good people. Well, I seem to be the only person who sings about it.
No thanks.
So
how does that make you feel? Is it just the whole noise around you just don't get it yet? Because to me, you've done so many scans that you truly know that in the nuance of angling that plane, you can refine even more a subject that, I mean, an item you're focused on.
Yeah, that's part of what you do is getting the thing absolutely in the middle, because that produces the best picture. And I think people understand it at different levels, but I know it's not, as far as I can see, it's not actually being taught as a reason for doing. People are told to keep things in the middle of the screen, or told to be at right angles on it, but it's always made it in the with this mantra that it's an anisotropy that makes it. And that means that people don't try hard enough, and therefore they lose part of the resolution. And that's the point. But if your students are not being taught it, if it's not accepted as, then I think it's a bit harsh to teach it, to examine on it, or to mark people down on it. I think possibly you can use the examination and things to emphasize it a little bit more, and maybe make the point that taking slice thickness into consideration, particularly for linear structures, is an important factor, and that it should be brought up to something people should know about. And then it's about maybe getting off my backside and publicizing my opinion, and this is all my opinion. But
no, it's more than opinion, John, because I believe that in your mind you see an appreciable change on the image with a 5%, or the same rule you were telling me about. Your mind sees a change, and if the viewer, if your student is keyed into that change, instead of just being thrilled that he sees the structure we're talking about, even if it's blurry, I believe that to the interventional person, knowing that they can actually pull out the planes even a little bit better after they've refined anisotropy is imperative to the interventionalist. It just seems to me. So more than just opinion, it seems like there could be a cine loop that you're accumulating to go, hey, this is an excellent example of where I can show a refining of that particular whatever. I will tell you, it's not so much an opinion. Do you agree?
Yeah, I will look up. In the scans I do over the next month or two, I will try to demonstrate that it's more than anisotropy when you're looking at small nerves. They don't make terribly good viewing, because these are very small structures.
Yeah.
And to the untrained eye, or to the inexperienced eye, it's quite hard to go and see these things. As we've discussed, the eye has to has to learn to appreciate the picture. But yes, I think that's an eminently good thing to do. I'll try and look out while I'm scanning, perhaps while I'm doing some practice scanning at home.
Is it possible for you to break it down almost robotically in your scan so that you could be talking out loud? There are aviation films where these guys are now on YouTube actually talking what their brain is doing, and I
Yep.
actually find it quite good, like Airspeed Alive, and we're now at VSO and those kind of things. To me, to hear John say, we're beginning to identify that coming into the screen is the long head of the biceps tendon. We'll bring it to the center of the and I'm not trying to tell you what to do, but my
Yep.
next
No, I get
follow-up
it.
question, John, is going to be, as you refine a anatomical structure,
Yep.
is your first step centralizing it and focusing correctly on it? Is the second step doing anisotropy adjustments? And is your final step making sure that the slice thickness orientation is correct? Because the follow-up question after that is, what percent? What
To me, it's one process. You put the thing in the middle, depending on how much of a hurry you're in, and how big the structure is. But for a small structure, we're talking a branch of the perineal nerve or something like that. You then it's beyond an anisotropy. These are very shallow structures. You're not really, if more often than not, you're deliberately causing an anisotropy in these structures.
yes. Uh-oh, I'm losing you, bud.
Make it what only see smallness often when you are really at 90 degrees. So you have to get. Sorry, we're having some issues. I'll just see if I do some things. Are we back with you?
Yeah.
Yeah.
Now
So
I've got
yes, we'll look at some small nerves and I do that. And I literally just in the last few days managed to get a mic that actually fits into my my recorder. So and for that purpose. So hopefully I will be able to, and obviously only with patient's permission, be able to record what audio while I'm scanning.
That would be fabulous to me.
Yeah.
As I think I just heard you refine, is getting it to the center of the structure is a no-brainer. Let's not even consider that, because that's what you're looking at. However, as you're taking from the mainline nerve and you're attempting to follow the offshoots or the roots of the nerves, you're taking it from bad to bad, going up over good, in order to be following that tube and keeping it refined. Once
Yes.
we break off into a peripheral item, as it gets smaller and smaller and smaller, to you, that's when the slice thickness is the most advantageous, because we're refining the small fiber of what we're looking at. Is that correct?
Yes. It's as you're approaching the limit of your resolution. When something is like the whole width of the long head of biceps, you get a better picture, you get a better quality picture as you scan, with taking into account to the level of accuracy needed to make a difference to slice thickness. But you still can see the structure, you can see the pathology, just adjusting for anisotropy reasonably well. It's when you start to want to see the really small things that it becomes important. And
so
depending on what's really small depends on the quality of your scanner, on the how high a level scanner you've got.
Pulling out the nuances of infraspinatus, supraspinatus, pulling out the nuances of the rotator cuff cord, the fiber directions on that. But as you are looking at the iliopsoas tendon, are you at all caring about slice thickness?
Yes. But
so, so that's important to me, because
it's your picture just improves the amount of signal. So for something like psoas or for supraspinatus, it's important because the fibers go in different directions and change direction rapidly. For something like psoas, it becomes important because you've got because of its depth and the generalized reduced quality of the image. So you're trying to get the very best out of the image. So you get the best, the strongest returning signal by being really precise.
The deeper it goes, John, the deeper it goes, is the dimension of slice thickness wider, so that as I do this type of thing, those fibers can become more.
It certainly it has that. I don't know that anyone's, or I've not sat down with a phantom and worked it out.
Yeah.
But yeah, the slice, as you go deeper, the slice thickness will get larger, like all the other bits do, and you start to lose that spatial resolution in all directions. But you've got, but more important, looking at these deeper structures is often, and certainly the larger ones, more important than spatial structure is signal to noise. And so when you're going down deeper, it is your signal to noise that becomes even more important.
I don't even understand what you're saying to that, John.
Have you noticed how the picture just gets worse and worse and worse as you go down deeper?
Yes.
Now, that's because there is less of the signal that's going up and down. You can just amplify a signal that comes back. So it almost doesn't matter how far down. You can theoretically get a picture. What happens is that there is a lot more noise in the picture than that. There's a lot more sound coming into the scanner that is caused by something other than the reflection of from your target.
Because you're listening to all the noises, desperate to hear the background worm drive on the video of Hunt for Red October. I mean, all the other noises are so embellished because you're so desperate to hear a signature
because you're magnifying, because you're amplifying the signal so much. It can be 1,000 times more amplified at the bottom of the picture than it is at the top of the picture.
And when that happens, the neighbors shouting, you're going to be hearing noise from them as well as everything else. And so it gets a lot more fuzzy, a lot less refined.
Yes.
Now you call that signal to noise because the signal means the actual quality processing. It's the one you're looking at, and the noise is the background chatter.
Yes. Yeah. So that's your signal to noise. And because that deteriorates so much, anything that produces a better quality signal is going to be helpful. So when you look at when you think about anisotropy, you think within 20 degrees you've got rid of anisotropy. Well, that's not true in actual fact. You only get rid of anisotropy at 90 degrees. It just matters less in most of the picture because the signal to noise is relatively good. And that's one of the reasons why I'm often dropping. My first reaction, as soon as the picture quality goes down for any reason, is I drop the frequency down because that, in most cases, vastly improves your signal to noise. So, and then so it isn't just at depth. Anything that reduces signal quality, I do that. But you then have the thing that you can make your signal better by actually bouncing straight down off the top of the ball. If you think about bouncing one ball on another, you get the ball back if you're within 20 degrees, but you get it back a lot more firmly.
Yes, that's brilliant. Yes.
Bang it straight.
Yes.
And so the deeper you go, it isn't about looking to see whether it's bright versus dark. To actually be able to make anything out of the picture, to get the last bit out of the picture, to get a good quality picture, you have to be right on the numbers.
So I can understand, as we're short axis on a tendon, making it go bad to bad, going through the perfectly incidental reflection. Now, the slice thickness, however, on that is modified by rotation. Am I not correct?
Yep.
So as we do anisotropy in what I would be calling a WAG, we're going to be doing the slice thickness variance by doing a rotation.
And the WAG as well.
So slice thickness also has to do with WAG.
Yes, but whereas anisotropy is not really affected with the with this movement so much.
Rotation. So how you're actually saying that slice thickness also is affected by WAG is because I'm moving a plane down deep, and I'm trying to get the echoes to come up at the exact same time instead of having the echo along that line come up at different times, because it's represented by a pixel, and that pixel will grayscale out if I'm on a plane. John, how am I doing, buddy?
Not bad at all. I think you've got it.
But it's the nuances of what I'm telling you. I have to first know before I can get that what we call English on my on my probe. But now you're saying, as you're doing an anterior hip, you're actually worrying about slice thickness still at the same percentage.
I'm worrying about being absolutely right. I wouldn't necessarily. It's more. I don't necessarily separate it out. Slice thickness is more critical. The what you notice in anisotropy, you notice the anisotropy effect with a broader stroke. You notice the slice thickness issue in the very much more precisely. They're both effective there. What matters is when you're looking at the anterior hip, you're not thinking necessarily about slice thickness, because you're not worried about your 0.2 to 0.4 millimeter resolution, but you're interested in the signal to noise issue, which is affected to a certain extent by slice thickness, but not as much as it is just the amount of, you get more sound back. It's in terms of looking at things at depth, it's often the more important factor is just physically the amount of sound you're getting back. So you want your maximum signal to noise ratio, and you want your most precise borders, and that's the slice thickness, that top border of the tendon in a psoas, to be able to pick it out as it starts to dive down. It is more clearly defined by that when you're right on it, and that is partly the anisotropy, but also partly the slice thickness.
Do you have the ability to control signal to noise ratio in these huge cart systems? Are you able to take power of that, or it? Because obviously in these portable ones, it's like an Instamatic camera. I'm not able to change that.
Then you can. You generally don't, because the systems like your portable are usually set up by people who know what they're doing, and they're trying to get the best out at the bottom of the picture. The only things that you normally mess around with on the cart-based systems or yours is the frequency. Frequency is the most obvious one. It's in my opinion, mostly down after frequency. It's mostly down to technique.
What about these multifocal sites that they do, or these things that look like a equalizer on a sound machine? Do you play with
that? That helps, but in a much more superficial sense. What you're doing there is you're adjusting the gain, and it's easier on the eye if you're looking down low and you're trying to increase the amplification to get the best out of your signal, to be able to reduce the amplification higher up in the picture, because it allows your eye to adjust because obviously the brighter you have the picture, the more damping there is within your eye, within your own interpretation of the signal. So by turning down the gain elsewhere in the picture, you can actually improve your visualization and make it more comfortable visualization of the deeper structures.
But you're not altering the physics of the machine. You're altering the digital post-processing in the actual display when you're playing with that kind of stuff. You're not refining the physics of your image. You're simply making your eyes able to see it better, like brightness and contrast and stuff like that on a TV.
Yes. Yeah. It's essentially the physics is you adjust the focus to be at the bottom. Multiple focuses don't make any difference in that sense. They just slow your picture down. So if you're just interested in one area, you put the focus on that, but that helps. You see how effective your compounding is. So some of the more powerful machines will allow you to adjust the amount of compounding you have. You familiar?
Why would you showed it to me because on the screen you showed me shadows at different angles, but to me, if a person has the ability to pull out compounding, when would they want to do that?
It becomes more problematic. Well, compounding will only work to a certain depth based on the width of your probe, and that might be an issue. You also the directions the sound is going from. Sometimes you only have a relatively small window through which there is a good signal coming, and so you might feel actually you're going to because for deeper structures, if we just can I share for a second?
Oh, I want you to, man. It's time to transition.
No, you're gonna have to make me.
I'm just trying to make you beg. I apparently want to have you have to ask me for permission.
Yeah.
I wish there was, the first few times we had these chats, I didn't have to do this.
No, something changed during an update. They've switched it to, you're having to manually.
But I was able to make you a guru here.
You make me the host.
You're the host now. I'm just going to do that at the very beginning now, since I don't know how to work with any kind of technology here.
Okay, yeah. Let's see if I go whiteboard. Yep. Let's see if this works. So we're going to start here. Just going to wait. Yep. Okay, so where's my mouse? Where's my mouse? Sorry. I'm just going to raise. Still
while you're doing that, let me ask you this: your analogy of a ball bouncing off of a larger, like one of these Swiss balls or these gym balls, and coming back to my hand. In the compounding, are we throwing balls at the same time at the ball that actually has the plane or the axis, the center of the ball in mind, or do we have lots of balls coming at 20 degrees, then some coming at 0 degrees, and then negative 20 degrees? Is that?
No, this is how it works.
All right. Oh, I'm looking at you.
Yeah. So there's your target.
I'm seeing nothing, John.
All right. Oh, that's no good. I thought I have shared this screen. Can you not see it?
I can see a pointer, a black pointer on the screen.
But you can't see the picture I've just drawn.
I cannot see that.
Right, let's try again. Share screen. I'm going to share the whiteboard. I'm going to share it. Is that up there now?
It says John has started screen sharing. Oh, I got it. I got it. I have it now.
Okay. So this is the probe. There is a lag on this for some reason. That's my handwriting. It's awful.
I did see probe now. I can see that.
Yeah. So that's the probe.
That's the footprint of the probe, yes? And then down below.
The target.
Yes.
Yeah. And this is the pulse that shows that target.
Yes.
Yeah. So the sound goes on a standard ultrasound picture. You get all the sound just goes straight down.
Yes.
Yeah. And compounding makes another picture where the sound is sent in that direction. Yeah. So
Yes.
a standard image is like a net curtain. Do you know what I mean by net curtain? No. Do you remember those people? There was a fashion for having doorways without doors in them, but just beads going down.
Beads. That was the groovy era, buddy.
Yeah. That is a standard ultrasound picture.
Okay.
Yep. You get a pulse of sound, goes from one point at the top of the screen, it goes down, it bounces back off the structure, and it comes back, and all the little dots along it are that. And you stick a whole load of those, and you do that 100 times along the length of the probe, and that gives you your ultrasound picture. Yeah?
Yes.
Yeah. So what this does, what the compounding does, is it makes that picture there, and then it makes another picture like that by sending the pulses out at an angle. And then it makes another picture going that way. And then the three pictures overlap. And it makes a compound. So it adds all the pictures together. So what you get, if I show you here, is that picture plus that picture plus that picture. Does that make sense?
It does make sense.
Yeah.
Yes.
What you get is within this area, you have three pictures all stitched together, giving you a picture. Within this area, you have two pictures stitched together here. And beyond a certain depth in this picture, you only get this picture.
All right.
Yeah. And you can work that out on your screen by looking at how the what the angles are that it comes off. But there are times when, if we go back to this picture here, so you're looking at something right down at depth there. Yeah.
Yes.
And this is here. Now, your compounding is going to give you a better view of this because it's adding up three different angles on it, which is why it gets rid of some of the anisotropy.
It's going to give me a better summation of this structure.
Yes.
Okay.
Yeah. Now, however, if this is rubbish tissue here and this is rubbish tissue here, then those summations will not necessarily be helpful. And so occasionally, if the picture is rubbish, but there's lots going on in the picture and you're looking at something quite deep, and maybe you've only got one single passageway. Say you were trying to look anteriorly at the and I'm not suggesting you would do this clinically very often, but if you were looking at the spinal cord through the anterior abdomen, and so you were trying to look through the extreme cases when you're looking through the using the disc as a window to look at the spinal cord,
like of an infant or a baby. No. Or can you do this on humans?
You do it in adults.
Unbelievable.
A friend of mine I did some pictures for a friend, and he published a paper recently on it. So it's eminently doable. I can pick some up and show you.
I would love to see that exposure, but I'm listening to you. Yes.
That's what I mean. It's when you it doesn't happen very often, but sometimes the compounding, because it's all coming at different directions, and therefore, if you've got the anisotropy, if you can get on the right angle here, sometimes that will give you the best. That just that picture there is better than the summation of all the others. And so sometimes, not often.
Would you say that the frame refresh rate can go up if the processor is loaded down by compounding? Is there any secondary value to the refinement of basically just not loading down the CPU?
Yep. No, that doesn't, in musculoskeletal, that happens less often, because obviously you've got because the distances are not very far. But they're, sorry, I'm just getting up a second screen. But yes, you will get a better frame rate if you turn your compounding off.
I now want to go exploring with you on images and case studies.
Yeah, good. Well, I'm just going to play around with some of what I've got. So bear with me just 2 ticks.
Yeah, no problem.
I've got here. So if I get up another window and come up. I love my Mac for its ability to drive 2 screens and multiple desktops on it, but it does my head in sometimes. Spinal cord. Spine? Yeah. And we will go vertical disc. Yeah, I'm going to see if I can find them quickly. If I can't, I won't waste your time with it, and I'll dig them out another day.
I will tell you that my level of ultrasound exploration has discovery moments that embarrass me to even admit. I remember a rather lean young lady. I was attempting to explore imaging the rectus abdominis, and I went long axis to see if I could see the tendinous inscriptions, and you know, those little things that I wanted to be able to see if you could see the 6-pack or whatever. And then all of a sudden I was deep enough, and then it dawned on me: are those bright things in the distance actually vertebrae? And John, you know, I'm a physical therapist. I know good and well where anatomy is, but I don't know why it was. I'm now looking for wedge fractures. I'm looking for, you know, elderly compression fractures. I'm assessing the listhesis now of because I didn't even know.
You can see on slim people, you can see it. I think it's JPEG. Spine, lipoma. All right, yeah. So if I share this with you, this is a lovely picture. I'm afraid it has been published in a paper recently. I took it quite a long time ago, 2010. You can reproduce it, but it is quite tricky. But you will find it funny, I think. I share that. Can you see that?
I can.
Okay, let's make it a little bit bigger. Okay, so you got the skin, you've got the aorta there. You've got the intervertebral disc, and you've got the cords of the cauda equina here.
My land! I had no idea.
Yeah.
What made you even say that, hey, I should try to even look for this, John? Because you know you could?
Why would you not? Because you can see the spine. And then you just go.
Don't you shame me, buddy.
But look, you get this picture of the spine, not on a slim person.
Yes.
The spine is like 2 centimeters away from the tummy wall when you press, and you can see the disc there. So my first thought was, well, if I get that in the middle of the screen and make it horizontal, then I should be able to see right back to through the other side.
Unbelievable, John. Yeah. I never even, I guess I just didn't take it to the, what about that? Show me the other one again. Oh, look at that.
Yeah.
Those are actually the descending peripheral nerves, or that's
the caudate equina. Yeah.
Yeah. Unbelievable. Give me an age. Are we talking 35? Or are we talking what?
You see that in slim people, and but yeah, probably slim. When I occasionally, if I'm at a conference and because you won't, on my scanner, on my little portable GE, I can see the space quite nicely, and you can see the chord or the chord space, but you don't see this beautifully defined nerve roots.
So give me the words that explain why you can see them here. It just has more power?
Because this is a top level machine at the time. So its slice is more, it costs, that was £100,000 scanner as opposed to a £20,000 scanner. And that's what physics spend that money.
Physics says that the slice allows for more processing power because the slice is thinner, and they can do that,
this will be right down just to slice thickness. It's how well constrained the sound is going back in and out. Largely, wow. I would say that this is probably just the sheer build quality of that probe.
I have access to the highest end Philips sonocytes and several ones at a course I teach in Vegas, or at least I'm part of the lab faculty for. And we have 35 models, young, lean lady models. I am all over this, man. I just need to know how to refine what switches you needed to throw in order to see this, because I'll be using $70,000 to $90,000 units. I would have never known. And here you are saying, well, why wouldn't you?
I've never seen anyone else do that. And I showed the pictures to a friend of mine, and he put a small paper out on it. But it doesn't.
I want to see the paper. I want to have. Did you get your name on it, like an et al?
Yes, I'm one of the et als on it.
I want to see it, man. That's a buddy I know.
Yeah. Hang on. Let me see if I can get the.
Hey, look at that, John.
Where did it go? So that's transabdominal imaging. Yeah, that's the paper there. If it shows up, yeah.
So can you give it to me? Oh, look at that. It even has a PDF. I want a copy, man.
Yeah, well, transabdominal imaging of the lumbar spine with portable ultrasound.
Look at that. These were images that you took of you doing it, or did you restage it?
No, I showed. I just did some. I showed him the pictures I had, and then I think I took a few of his spine, just to have ones that were relevant to the portable scanners that we've got.
Yeah.
He wrote a paper on it. So.
Unbelievable, John.
So yeah. I think it's you. Like with everything, you just have to go there.
Oh my! I love that. I love that discovery. Is there anything more that you were prepped to show me, based on my totally mealy bullet points that I was going to get to today?
I think I just went through, and there were the MP4s. I spent a lot of time last time just showing you videos, and it did occur to me that though I think that has value, I thought we might just, to get the best bang for your bucks, I thought we'd just see what would happen. I've not previewed these. I just run through. I just searched for JPEG and I thought we'd
Okay.
maybe just have a scout through.
Absolutely.
So that's a nice old slide. I think that's actually from Codman, which he wrote the
Wow.
original book on shoulders, which I went and bought and read. 6 months of hell, because he's a dreadful writer. But it was still an act of love. You know, he was just.
But this is the father of the pendulum exercises. Is that correct? The Codman.
Father of everything. Father of clinical audit, I would have said.
What about that?
But I wouldn't go as far as to recommend the reading. But if you had the time, it's something that I appreciated it. So what have I got? You know, there you got nice. This is really obvious. You might even say that the bone isn't quite bright enough there. I could probably be more accurate on that. There, here, this is where it's torn. That looks like the tear, but it's not. It's actually, that's just a stump, and this is a proximal tear of the supraspinatus. So it doesn't come off the end, but it's ripped further back. They're very uncommon.
We would say this would be a bursal tear, or is this, in your opinion, a full thickness retraction?
This is a full thickness tear. There's the cartilage.
Gotcha.
You've got a bit of debris. There's no meaningful tendon at that point. What you've got is one that is torn proximal to the greater tuberosity.
Yeah.
So you've been left with a stump there.
Rare, because the normally it comes off of the actual footprint.
Normally it comes off from the footprint, and that's the typical for your 85% of tears that are degenerative, and they tend to go there. I'd be more suspicious of something traumatic, perhaps with some sort of underlying pathological changes. You know, something that is compromising the tendon. You know, you'd certainly think about those things. This must be an old picture, because I never measure. I never measure tears anymore. But yes, there I'm measuring the width of the tear. And there's a nice, and they're just pretty pictures. What was I? That must be a normal picture. Yeah, these are just some normals I did. So they all just come up on the thing. That's a little bit more subtle.
Back up one for me, John, and talk to me a little bit about the fact that I believe I can see the classic, at least the terminology would be a cartilage interface sign here. And at one time I told myself that if that ever existed, everything above it had to have been compromised. But I believe that there must be the ability to identify that cartilage plane or that interface just as a rule of good scanning, or
yeah, that's just being right on the numbers.
All right.
You know,
we would expect to see darkening, and we would expect to see allowing that plane of the bursa to drop into the space, and any number of things that would give us an idea that it was torn. Other than that,
you can see in there that echotexture is absolutely normal, but it isn't the static picture that counts. It's the fact that as you scan through in short axis, if you are right in the perfect plane, you will recognize all these individual dots. You know, these dots, the integrity of these little tiny dots here will continue.
Yes, opposed to
that's why you have to be precise, even on supraspinatus, because the tears are difficult to find.
It could be just fibrotic tissue in a complete slice, whereas they would be linear collagen if they would be continuous with your scans in short axis.
Yeah, because if you consider each of these tiny dots as an individual tiny tendon, you should be able to follow each one individually. Yeah. And that's what you do. And if you can, then it's not a tear, because torn tissue, you just see a mush. And that mush may look similar grossly, but you don't get that precision, that tiny, bright precision.
And when you're following those fibrils, the slice thickness is important simply because now it's not just anisotropy to make it bright, it's refining the pixel to make it precise.
Yes, so each of those little, if you can see where I'm pointing there, there's some pixels there, there's a bit of bright and a bit of dark. You'd expect that pattern there, just like looking at the internals of a nerve, to remain the same if you are keeping it very precisely at absolutely 90 degrees.
As you're sweeping the short axis from the direction of the muscle to the insertion. All right, I'll let you continue. To me, it was just one of my biggest failures was to every time call the cartilage interface brightness a tear. I mean, good night. Talk about making a bad name for.
You aren't the only one. Trust me. Plenty of radiologists have done the same. But fortunately, they learn, because they then go on MRI these things. They learn their mistakes. That's what makes them stronger. It isn't any gift or education. It's the fact that they get the correlation, and that has been a key part of education, and it's the holy grail is correlation.
I hear you. That last one was a long axis, and we were able to see that you at the time were measuring the cleft. Again, it looks like there's a stub at the superior facet, and I can see a drop in the bursal line too, a little bit.
And given the texture you can see there, you wouldn't expect there to be an anisotropy there. And there you see it in the other plane.
Yep, I got it.
And so the classic biceps, a really small tear there. I wonder what I call that. Sorry, I'm just interested.
How do you know how to call it? Oh, you're looking at I got you.
Yeah, I just in my notes, I noted them. So I wasn't brave enough to say exactly what, but I presume that I'm calling that a partial thickness tear, because I've called it a subtle tear. But yes, there's definitely a tear there. And again, this part of the video probably can't go out.
Yes, the top part, correct?
Yeah.
Yep.
Just a nice irregular tear, nice fluid-filled bursa there. Lovely. That's a full thickness tear. You know, people start worrying, well, is that complete there? That's not holding anything together. So it's debris. It's not even in a straight line. You know, so we're not talking that's not partial thickness tear. Is that the same case? I wonder. Let's see. It's difficult to tell. 67-year-old male. Yeah, so this is the same tear in the other plane. So it's actually gone on and developed. There's a split there within the tendon, but I think that's probably looking more proximally. But at the insertion, that's a full thickness tear that extends into a split. They haven't really captured. These are just classic, nice little pictures. These I love, where you really have to. Sometimes you really have to work hard to get the angles right to make this abundantly clear that there is actually a full thickness tear there coming down.
Now, to what extent are you asking them to abduct against you? At what point do you actually do dynamics to load those fibers, John?
When there's any uncertainty.
So universally, when you come to this picture, not universally, I guess, if you had this picture on static, you would not have to say push against me to see if it retracts?
I would almost certainly load this to see what happens. I wouldn't rely on the retraction as something that always works with the resistance, because sometimes the muscle doesn't fire, sometimes the mechanism holding it all together doesn't show it. But usually, if it's ambiguous in any way, that will help. That will help to pull it.
Now, are you doing pure abduction, or are you doing a 45-degree abduction forward flexion? What are you doing to load this?
I just literally whatever position I can I need to get to be able to see the tendon well.
Then tell them to go at 90 degrees or
and then I've got my hand there and I load it, and I don't really worry too much about anything technical. I might change the direction if I'm not getting something, but you just do whatever you need to
most
simulate.
of the time. Are you crass or modified crass or what is
I'm karate punch position.
Help me. Karate punch like here.
Yeah. So can you see? I can't see my picture.
I can see you, and so you're just telling them, yeah, that's how you do it. You don't worry about the palm being flat behind the back, and you don't worry about it being on the back pocket. You do a Leddy karate punch.
I don't use either of those. All I want is a bit of extension. So my favorite way to scan is with the patient on a chair with a small back, a low back. Old-fashioned cheap chairs are the best. And then the patient, because they're typically older and they've got stiff, sore shoulders, I get them to lean back on the chair. So can you see my chair now?
Yes, I can. I've got you.
Yeah. And the perfect way is just to let the arm hang.
You got to now move forward, bud. There you go. All right.
Okay. The arm just hangs off the back of the chair.
Oh, really?
And then comes forward. Because if you ask someone to push their arm back and it's painful, they tighten up, which makes a bad position and is no fun for anyone. If they lean back on something and just let the arm hang down,
yes,
you get all the extension you need for over 99% of shoulders. And then the only other thing is I get them to turn the palm to face forward.
Wow, you even do the opposite of a pure crass where you turn palm in and like the arm.
I don't want any internal rotation if I can avoid it. So what I do is I scan with the patient. They don't have to be leant back. They can just, if they're fit and healthy, they can just do a straight karate punch position. But for the most time, I get them just to lean back and just let the arm hang under gravity, just like a Codman swing. So like a reverse Codman swing. And then they just turn the palm forward. And if I can, I rest them against the leg of the chair because that they find that more comfortable and they don't accidentally cheat and turn their arm in. That gives you the best views of the shoulder. What it doesn't do is in a tricky shoulder or a shoulder with a bigger acromion, it doesn't give you it doesn't allow you to see enough, and it doesn't stress the structure enough. And so when I've done the scan, if I want to check further, then I just introduce internal rotation.
And you do you do it for them passively. You'll just take the arm back and take it inward.
Yeah, well, you've got it there. Can you see me?
Yes.
Yeah, and you just want them to do that.
And that pulls it out from under the acromion.
That brings it further forward, puts it on a bit more tension. At the cost of twisting the fibers round, and if they've got a big deltoid, big pec, making it, or they're just particularly large, you have to come round a lot. So it is technically more challenging. You lose in some of the ladies, you lose the long-headed biceps. It becomes very difficult to visualize the anterior fibers of supraspinatus accurately.
How do you approach them? Are you sitting behind them, John? Are you sitting in front of them on a stool?
I never sit. I always stand, and I always stand behind, because when you sit in front of the patient, you have to have your arm up like this. Yeah?
Yes.
Yeah. And unless you are a surgeon or particularly strong, you're using your strength to stabilize the hand. And so you are less likely to be able to do fine movements unless you are a very experienced arthroscopist and you've developed such great muscles here. For weak and weedy people like me, you're not stable at the elbow.
No, I hear you.
Any so it's hard work, particularly with your probe, but it's hard work.
Yes.
And because it's hard work, you're having to, the muscles in your hand are having to fix, and so you don't use the subtlety. Whereas what I want to be, you're much more difficult to make any precise movements, and so your aspiration for how much subtlety you use in your scanning is always played down, which is why I think people haven't developed the subtle techniques in the shoulder. Whereas if you're standing up, your arm is resting down, and you therefore have a tiny lever arm, and so your muscles in your hand have so much less to do, and so you need a low enough seat. So it's a little bit problematic when I'm teaching short people to scan long, tall people, because their backs are so long and they're hitched up like this.
Right.
But for the vast majority of people, if you can get a low chair, you're standing there, and it takes a bit of getting used to, but it's a very, very straight. It's a much more relaxed, and therefore your hand will not have to work so hard, and you will be much more stable. And those are the important things for scanning accurately.
I think those are fabulous ideas. I'm now reaching that point of where, because I'm very interested in what you're saying, I forgot to remind you that you're 15 minutes late and you need to be helpful in whatever.
My wife just told me I've got to go.
Again, apologize to her, John. I'll get back to you because there's so much more I want to still learn from you, but I want to make sure that this has some level of confidence inside of you that we're getting somewhere. And all I can tell you is that I would like to then, well, let me do some thinking about what makes my heart feel better for you, and I'll send you an email or something and we can talk more about that.
I get a lot out of these sessions because it helps me articulate what I'm doing.
Well, buddy, if that's the case, I'm going to send you an invite for next Thursday, and I will outline some questions we'll answer. And if I just happen to have everything worked out that you can watch me scan, well, that'll be selfish for me. Go tell your wife hello, and thank you for your time, John.
We'll see you later. Cheers.
All right.
Bye-bye.
Bye-bye.